If I can get the other panelists up here, we'll try and have a relatively abbreviated panel in respect to the George Bursey video. If I can get the other speakers to come up and join us on the panel, maybe we'll quarantine Feza and John to sit together in case they have the same strain of virus and everybody else spread out. But there's one, we need one more chair. There are 5, but you guys got to kind of do your own housekeeping arrangements. There are floor microphones that we can certainly use, and as soon as everyone gets seated, we'll can squeeze in there if you like. So we got a mic back there. We have John over here, and we can start with the front microphone for a question.
Hi, Eric Liederman from St. Louis. I had a question for Dr. Sands. I've got a small collection of patients who've had TEMs for T1 cancers, wind up having unfavorable pathology, and then they refuse a radical resection. And our compromise has always been to give those people post-op RT because we don't know what else to do with them other than watch them. What's your thinking about post-op RT after TEM for any of these lesions?
Well, I think certainly for a T2 and a T1 with unfavorable histology, I would also want to do something else other than just watch. So I would do the same.
Anybody else? John, you do TEM.
Yeah, well, I think that, there are all flavors of T1 cancers, but unfavorable cancer, I mean, clearly the literature supports somewhere between a 5 and 11% incidence of node positivity. So, and if you look at the Norwegian trial, they reported that was exactly their failure rate. It was 11% in their local excisions, that they did nothing more for T1 cancers. So unequivocally, that patient should have more aggressive surgery, definitive radical surgery, or have post-operative chemoradiation.
Yes. Yeah. Okay.
I'd just like to add something to this thing. Most of us at the clinic, that the T1, it depends on T1, Caucasian 1, 2, it's okay for a local. The one that you're defining, I really do think it really depends on how we present things to the patient. That more and more I hear this refusing stuff. I really, the presentation is very important, and when they understand the concept of the fact that their life may be in stake, their mind may change. So I just like to add that on. It really depends on the presentation on this one. First line of therapy, in our opinion, on an unfavorable T1 is proceeding with a formal radical resection.
Yeah. I'll have them call Dr. Ramsey next time I have one who refuses.
Did you have a comment as well? No, nothing from Dr. F on that. Now the question from the front mic.
Hello, I'm Sam Diba from Beirut, Lebanon, American University of Beirut. We've recently started doing the TEMS at AUB, and we came over a couple of patients that were favorable histology, and there was negative tumor cells on margin. However, there was mucin on margin, and it was kind of a dilemma. We didn't find anything in the literature that says how we follow up these patients, or should we go ahead with a radical resection? What's your input on that?
The
I mean,
significance.
the question is really what's the significance of acellular mucin after chemoradiation and resection? And so,
no chemoradiation, only resection for T1 favorable tumors using TEMS.
No neoadjuvant. There's just a patient.
Yeah, it's a T1
had a
tumor.
T1.
It's a T1 tumor that was resected using TEMS. And
Okay.
pathology came back as no tumor cells on margin. However, there is acellular mucin on margin of the T1 lesion that was excised. It is a kind of a dilemma. I didn't find anything in the literature that quoted that. So I'm just bringing it up. What's your input on that? What should we do?
that doesn't sound right to me.
I wouldn't be
I
comfortable
would
with the
have to
margin.
look at that
You wouldn't be
pathology
comfortable.
slide myself, because I don't really, to have acellular mucin on the edge of the,
The section margin.
I would not be comfortable with that margin. I would,
Do a radical.
or re-excise it.
Yeah.
I think a negative margin means you see normal rectal mucosa.
All right then. Thank you.
Yeah, I think acellular mucin in and of itself doesn't mean anything, but normally it's after neoadjuvant. This is
Yeah,
like an
that doesn't sound right.
it's an odd setting. After neoadjuvant, if that's all that's left, that's not worrisome. But that's like a different issue. I don't know about at the margin.
Yeah, I was going to say if it was acellular mucin after neoadjuvant, then I would observe that patient closely. I would not commit that patient to an APR.
Right, that's, everyone agree on that one, right? Yeah, okay. While we're on the subject of TEM, do you always, if you don't go full thickness, do you always close the rectal wall? Because there's some teaching, and like Ian, for example, Ian Lavery in Cleveland doesn't like to close after TEM, or at least he didn't, transanal excision, because it says better to watch for recurrence, tumor bed, whatever. Do you always close?
I think I try to close everything. Radiated patients, sometimes I will leave open because I think they have a higher incidence of developing an abscess, but all of the other lesions I do try to close. I think you want to be good at suturing and comfortable with suturing in the rectum, and if you don't close anything, then when you get intraperitoneal or you're higher up than you thought and you're not experienced with closing, then it becomes a problem. But the radiated patients may be left open.
Feza, you had a comment on that?
So regarding, Ian, you're referring to, I personally don't do TEM, and we have the younger generation who does that. They do a great job.
The younger generation?
But you were the younger.
I am
When did you get so old?
Where does that?
So in our department, let's put it that way. Okay. So, you know, the posteriorly, I don't close that. Anteriorly, I do specifically on a female, so we don't get into vagina or something with the sloughing off, in that regard, or transanals.
John?
I agree with what President said. I want to ask Dana, on patients that have been radiated, my experience when we do the transanal excision, say we're looking for, is that everybody is completely miserable for 3 months with pain and discomfort. Yeah, with the radiated, I mean, when they get full treatment radiation, you do a transanal excision. Do you have a lot of pain and discomfort in those patients?
Yeah, I think when the wounds are open, the patients tell you the wounds are open, and they come back. A lot of patients after TEM with a closed defect, they say, did you really do the operation? And when their wound opens up, they tell you. They have fever, they have discomfort, they have tenesmus, urgency, mucus, drainage, and it can persist for, I tell them to be prepared for at least 8 weeks.
Do you keep them on antibiotics empirically after you do these TMs?
Completely unscientifically, I treat them with antibiotics for 5 to 7 days after. I find that they get a bacteremia, and I get phone calls with fevers and things like that, and I treat them with antibiotics. But when the wounds open up, I do treat them with a longer course of PO antibiotics.
So empirically, 5 or 7 days. You do the same, John?
I mean, I would say that, to answer that, I have an experience of 161 irradiated rectal cancer we've done TEMs on, and the wound separation rate after closure is 28% in the chemo-radiated patient compared to 5% in the non-irradiated patient, which we published in Surgical Endoscopy 4 or 5 years ago. I always close everyone. I think that what Dana described is absolutely what you see, is when the patients are closed and they heal fine, that they have absolutely no discomfort, and you know when they have a separation of their wound, so why would you leave the other 75% of the patients open? It's my opinion that the radiated patients are more important to close because generally you're taking a much bigger chunk of the mesorectum. There's a much larger defect in those patients. I think you have to mobilize the whole mesorectum very widely in order to close those patients. And we actually always keep the patients on a week to 10 days of antibiotics after this, because I think after you're sewing a radiated tissue to a radiated tissue, it's harder to get the antibiotics to the tissue, and it's also harder to clear it once you have a problem. Emanuele, what do you do over there? I was just, Professor Lazocchi's here. He has an experience with that. We might as well invite him into the
Can you repeat the question, please?
Do you close your irradiated rectums after TEM, and how do you use antibiotics in the perioperative period? Do you discharge people on oral antibiotics?
Indeed, as you know, I do a wider excision. In this case, we use glue. We fill up all the posterior cavity with glue, and this has reduced strongly the risk of dehiscence. So, and then we insert sponge inside of the rectum over the suture line. In this way, we try to reduce always the posterior defect that otherwise you leave a cavity. And the cavity, I think, is the main problem. We didn't find any difference between case treated with radiotherapy and not without radiotherapy if you use these two very simple way to do. And that's a strongly reduce the risk of dehiscence, because I think the dehiscence don't come from the lumen through the cavity, but come from the cavity to the lumen. That is the infection follow the less resistance way and open through to the suture line and make the dehiscence. So I strongly recommend to do these two simple things. Fill the cavity with the glue and use sponge, iodine sponge, inside in the lumen. So in this way, you practically have obliteration of the posterior cavity.
So this is like fibrin glue, you know? Like
Yes,
fibrin glue?
Fibrin glue,
Must be a sizable quantity. Huh?
Yeah.
I mean, it must be a lot of glue, because normally it's like 4 cc's for a
Yeah,
fistula.
we use two syringes enough, because then you fill up the lumen. That's the point.
And how
For
long,
3 days.
For how long do you leave the sponge in place?
3 days.
And Emanuele,
2,
what
3
is
days.
what have you seen with your wound separation rate in that patient population? And how many cases have you done that way? Because that's a relatively new approach for you.
We use from last 3 years. We are going to publish the comparison, a retrospective comparison of the 2 series of cases. And it's very interesting, I think. I learned this from colleagues that do not do TEM procedure, but it's useful also in TEM procedure. Thank you.
Well, let's say, staying on the theme of TM for just a second, let's say you do, I can ask Dave, you get a T1 lesion, you think it's a T1 lesion, and you do TEM and it's T2, and it's a otherwise, you know, healthy 50-year-old patient.
Sign them up for our notes protocol. That's what we do.
Okay.
That's what we do. I mean, we offer them I mean, if it's real low, it's a perfect notes TEM case. Or, you know, it's coloanal, but we would definitely we would treat them definitively. We wouldn't stop.
You wouldn't do, okay, anybody here would do radiation or chemo? No, everybody go for surgery, T2.
No.
Okay, for healthy T2. John, when you do your Tata procedure, what kind of reconstruction are you doing? Feza described a whole lot of reconstructions. What are you doing?
Preferably, generally we deliver the specimen transanally, and if there's enough length, I'll preferably do a cholanal J pouch. A fair amount of the time, I don't like the way that lies in the pelvis, and have moved to doing more side-to-end cholanal anastomoses. And then if I would say that while my preference isn't a straight cholanal, I'm perfectly comfortable doing it, and I won't suffer trying to, I don't think it's a sin to do a straight cholanal, and so I think it's worse to put your bowel, your mesentery on stretch to try and accomplish something else that doesn't fit nicely. So I will do a direct cholanal if there's an issue in terms of reach.
Okay, but preferably a J pouch. What's your preferred reconstruction, John?
Generally, end to side.
Yeah, so end to side, Feza. Out of all those different things you showed, what do you, if you could do anything, what do you think is
We
best?
do it in a study comparing J
I
pouch
know.
versus end to side.
I know, but besides for the study, I mean, if you weren't doing the study,
If it's feasible, I'll do a J pouch.
J pouch.
You know,
Okay, and then the other question, one of the techniques you didn't show, and I didn't know if any of the panelists had any experience with it, is the ileocecal interposition, like they do in Parma, Italy, where they just do the, not what you showed flipping it, but putting it directly on, putting the cecum on top of the rectum.
Yes.
Do
So
that.
what was the question?
Do you have an experience doing an ileocecal interposition?
Like the one that
Instead
I
of
showed you?
derotating
Yes.
exactly, you flip it the other way.
No.
You put it around. They do it, okay.
Do you think that's better than an ileorectal anastomosis?
No, I'm not, I didn't say, I'm asking the questions. I don't think, I'm just asking if you do it. No, I don't necessarily think it's better at all. Dave, in terms of these notes procedures, what are the prerequisite skills? If somebody came to you now and said, listen, this looks fascinating and I didn't realize all this progress had been made, you know, what do you tell them they need to do on the way up, knowing what you know now about the technique and the pitfalls?
You need to be a very good laparoscopic colorectal surgeon. You have to have patience, with patience, IENCE. You need 2 people. You need someone on top, someone on the bottom. You need to be able to do TEM, and you also need to be good at routine anorectal surgery, hemorrhoid, fistula, and so forth, and know your way around the sphincter, intersphincter complex. That's all.
What is the person up top doing? I mean, what are those, because I didn't see you go into that part that much in terms of what ports and instruments
So
they're
very
using.
much like Feza described, I mean, we routinely take down the splenic flexure, we routinely divide the IMV, and what we do is when we're about halfway, when we're sort of getting close to opening the pelvic peritoneum, we got everything else done, we start from the bottom and we try to meet somewhere around the mid-prostate. For some cases, we've intentionally tried to do more from the bottom just to see what the limits of what we could do transanally really is. And sometimes it's a question of time and people's availability, and you just want to get the case done too. So since all of us can do a coloanal, completely laparoscopically, basically, it just depends on who's on which side and how fast they're going.
And what instrument set are you using below? I mean, not whose brand, but what kind of instruments using below?
A TEM, harmonic.
So anything that insufflates that gives you visualization. You're not doing it directly with a Lone Star, in other words.
No. It's through a TE. You use a TEM setup.
Yeah, I just want to make sure we're clear on that with
Yeah.
folks, because
But to do the actual anastomosis, it's just like a coloanal.
Anastomosis
It's
is
a
open,
hand-sewn
sure.
coloanal. Yeah.
Right, John?
I actually found the first couple we did with the TEM, and it was hard. The long shaft of the TEM, one of the challenges is it limits your mobility to the right and the left.
Yeah.
And so I did a couple cases where I started with that and went up, and then I traded it out for a
Gel port.
for a SILS or
Yeah.
applied port, and
Yeah.
which gives you the ability to go to the side. The problem with that is the beauty of the TEM is there's a table holder. The Martin arm holds it, which makes it much easier. But I think it's an interesting approach. It's a work in progress, I think.
Absolutely. Yeah.
Well, I promised everybody we would try and abbreviate this so we could get down to George's video, so I would like you to join me in thanking the panel for some great talks.